mechanism. Vaginal flora, polymicrobial. Lactobacilli, also known Dodderline bacilli, predominant. Gram-positive bacilli appears at puberty, disappears at menopause. Glycogen in stratified epithelium, lactic acid plus hydrogen peroxide, acidic pH, that's the defense mechanism. Estrogen, responsible for presence of glycogen. Candida, survives in acidic pH. Pap smear, screening for cancer. Dodderline bacilli, superficial cells. Pap smear is done once every 3 years in normal results, and if there is any abnormality, then it's repeated at 6 months. Leukorrhea, physiological white discharge, increased during ovulation and before menstruation. So normal pap smear shows superficial cells and Dodderline bacilli. What is the characteristic of physiological leukorrhea? Colorless, odorless, consistency first half of the cycle thin, watery due to estrogen, second half thick due to progesterone, no pruritus, dysuria. It's due to bacterial vaginosis discharge. Differential diagnosis is bacterial vaginosis discharge, which is colorless, no pruritus, but pungent, fishy odor. So the normal discharge that every woman have, the normal staining of the underpants, that does not have a smell. But when it is bacterial vaginosis, it will have a fishy odor to it. Now, infections of the vagina, very common scenario in OPDs. You have to do a per speculum examination, take swabs to differentiate or treat them syndromically. So organism. So we are learning 3 types of infections: bacterial vaginosis, candidiasis, and trichomonas vaginitis. So anyone coming in with the problem of discharge, you start thinking about bacterial vaginosis, candidiasis, and trichomonas vaginitis. Amongst this candidiasis, you will be seeing distinct white discharge. It would be profuse, and trichomonas will be scanty and smelly. So bacterial vaginosis is caused by Gardnerella vaginalis, mycoplasma, mobilincus, alteration of vaginal flora, most common vaginitis in female. Candidiasis is caused by Candida albicans fungus. Trichomonas vaginalis is caused by flagellated protozoa. Predisposing factors: alteration of vaginal pH, alkaline pH. Candidiasis, pregnancy, most common vaginitis in pregnant female. Immunocompromise, antibiotics, steroids, oral OCPs consumption, and Trichomonas vaginalis coexist with bacterial vaginosis. Discharge: grayish white, dirty white, foul smell. Candidiasis: curdy white cottage cheese, not main complaint, scanty. Discharge: Trichomonas frothy, yellowish, greenish and color, foul smell. So pH is alkaline in bacterial vaginosis, could be acidic, less than 4.5 in candidiasis, and more than equal to 4.5 again in trichomonas. Pruritus: no inflammation, no pruritus. Intense pruritus, excoriation main complaint. Intense pruritus is a complaint in candidiasis. when many women complain about this. Intense pruritus against in trichomonas. Another is when there is a thinning of the labial skin and vagina due to lack of estrogen in menopausal phase. Then also there is intense pruritus. Dysuria not present in bacterial vaginosis. Splash dysuria present in candidiasis, and dysuria is present in trichomonas. That is burning sensation while peeing. Polymorphonucleosides, PMNs, epithelial cells, less than 1, bacterial vaginosis, more than equal to 2, candidiasis, more than equal to 2, trichomonas. STD, none in bacterial vaginosis, not usually in candidiasis, and in trichomonas, yes. Investigation of choice, saline microscopy. So you just have to take a swab and send it to the lab. What they see there is in bacterial vaginosis, clue cells, epithelial cells with bacteria adhered, clue cells, normal vaginal flora, and clue cells, see the difference. Candidiasis, pseudohyphae, spores of candida, candidiasis. Trichomonas vaginitis, motility present or tennis racket appearance. Pear-shaped organism, size of nucleus of the cells. Gold standard test for bacterial vaginosis, we call it BV. Gram staining, Nugent score 7 to 10. Candidias, culture on seborrhoid media. Trichomonas culture. Named test, whiff test. Add 10% KOH to discharge. Fishy amine-like odor. Amsel's criteria, grayish-white discharge. Alkaline pH. Clue cells, more than 20% of epithelial cells. Whiff test, positive. If 3/4 criteria positive, then it's called bacterial vaginosis. Candidiasis whiff test is negative. And then trichomonas whiff test is positive. For speculum examination, strawberry cervix, angry looking vagina. Drug of choice, non-pregnant women. Bacterial vaginosis, metronidazole, oral 500 mg 2 times a day for 7 days, or clindamycin. Then for candidiasis, as you know, it's just a 1 dose, 150 mg stat. And trichomonas, again, metronidazole 500 mg 2 times a day for 7 days, or 2 grams stat. In pregnancy, bacterial vaginosis, metronidazole, first trimester vaginal metronidazole, second and third trimester oral metronidazole. So very important to remember, if a lady is pregnant in her first trimester, comes in with whitish discharge and foul smell, and you find that she has bacterial vaginosis, what do? You give in the first trimester vaginal metronidazole, and in the second and third trimester oral metronidazole. What is the dose of oral metronidazole? 500 mg 2 times a day for 1 week. Candidiasis, oral fluconazole is contraindicated. Topical cotrimazole is drug of choice. So you cannot give fluconazole to our pregnant women. You have to give them topical cotrimazole. You cannot give fluconazole to our pregnant women. You have to give topical cotrimazole. Trichomonas vaginitis. So again, metronidazole first trimester vaginal, Second and third trimester oral, doses is same. Partner treatment not required in bacterial vaginosis. For candidiasis only in symptomatic. In trichomoniasis you do require the partner treatment. Spore of candidas are smaller than nucleus. Cervicitis. Ectocervix versus endocervix. Ectocervix, lined by stratified squamous epithelium like vagina, and endocervix is columnar epithelium. So this is important. Stratified squamous epithelium like vagina in ectocervix and columnar epithelium in endocervix. Infections. All vaginal infections can affect ectocervix as it is also a part of vagina. Vaginal epithelium type. So what are the infections that we just read? Candida, trichomonas. And new one is herpes simplex virus, human papilloma virus. Endocervix, on the other hand, could have chlamydia, gonorrhea. Infection of endocervix is called cervicitis. Whenever there are cervical discharges, what we do is take the GCTC swab to test gonorrhea, chlamydia. Chlamydial and gonococcal cervicitis. Most common route of spread, extending infection along with sperms, STD. That is the most common infection along with infection spread. That is along with sperms, STD. Most common site, endocervix more than urethra. Clinical presentation, asymptomatic, 50 to 80%. Discharge, most common presentation, mucopurulent. So there is a mucopurulent discharge. Dysuria, dyspareunia, postcoital bleeding. Per speculum examination, you will see unhealthy friable cervix, bleeds on touch, erosion and ulcer. Anytime when your samples are bleeding, then you say that okay, your cervix looks irritated. That is friable cervix, unhealthy, bleeds on touch, erosion and ulcer. Per vaginal speculum, uterus normal, adnexa normal. Differential diagnosis is pelvic inflammatory disease. Here when you try to move the cervix, you will have uterine tenderness, adnexal tenderness. Gram stain, chlamydia and gonorrhea. Chlamydia more than 10 neutrophils per field, no organism. Gonorrhea gram negative diplococci, intra and extracellular. So in chlamydia you are not seeing anything, they are very small. You are seeing neutrophils more than 10 per field. And in gonorrhea you are seeing gram negative diplococci, which could be either inside or outside the cell, and they are 2 in pairs, diplococci. Investigation of choice, nucleic acid amplification test. So you send the swabs with the forms to get tested for nucleic acid amplification test. Specimen, endocervical swab, urine if urethritis is positive. So endocervical swab, so you have to do a per speculum examination and take swab from the cervix, and urine if urethritis is positive. Also urine you will send in a different culture media. Gold standard, so chlamydia culture on McCoy cells line, and gonococcal culture on Thayer-Martin medium. Drug of choice, again non-pregnant and pregnant. So tablet doxycycline 100 mg once daily for 7 days. Tablet doxycycline is contraindicated in female. So you give tablet azithromycin 1 gram oral single dose. And injection ceftriaxone 150 milligram IM single dose. Usually they give 500 milligram. So doxycycline is not given in pregnancy unless there is strong indications. It is a tetracycline, only tetracycline which is to be used in pregnancy if there are strong indications. It causes bluish discoloration of the teeth and bones. Complications: pelvic inflammatory disease due to accent of infections, perihepatitis, Fitzhugh-Curtis syndrome. Management: syndromic management advised by NACO. Colored-coded kits based on history, per speculum examination, per vaginal examination, plus minimal investigations. These kits I have covered in a separate video in very detail, so you should watch that. Complaints: vaginal discharge, lower abdominal pain. Vaginal discharge: history of discharge, pruritus, dysuria. Per speculum, discharge from vagina, strawberry cervix. Per vaginal, normal, cervix healthy, vaginitis. Treatment for vaginitis: secnidazole 2 gram plus fluconazole 150 milligram. Discharge: history of discharge, per speculum, unhealthy, eroded, ulcer, friable cervix. Per vaginal, normal, Cervicitis. Grey kit: tablet azithromycin 1 gram oral plus tablet cefixime 400 milligram oral. Lower abdominal pain, history of discharge, menstrual abnormality. Per vaginal, any of the following: uterine tenderness, cervical movement tenderness, adnexal tenderness. Rule out ectopic pregnancy. Yellow kit 6. Supportive treatments: abstinence for 7 days, condom contraceptive, partner treatment cervicitis and pelvic inflammatory disease not indicated in vaginitis. Other uses of kit 1: for partner treatment in cervicitis and PID, urethritis, anorectal discharge, scrotal pain syndrome. So PID continued. Features and management of pelvic inflammatory disease. Definition: infection of upper female genital tract includes endometritis, uterus infection, salpingitis, fallopian tube infection, oophorytis, ovarian infection. Infection can spread to abdomen, peritonitis, perihepatitis, and the symptom associated was Fitzhugh-Curtis syndrome. Most common of route of spread is ascending infection along with sperms, STDs, most commonly seen in sexually active females, 13 to 15, 35 years. Risk factor: multiple risk factor. History of instrumentations: post-abortion, postpartum, history of previous PID, cut insertion, first 3 weeks. PID polymicrobial infection. Protective in PID: barrier contraceptives, condoms, Mirena. Pathogenesis: uterus, endometritis. Menstrual abnormalities: dysmenorrhea, lower abdominal pain, endometrial, biopsy. Tubes: thick, congested, hyperemic, swollen tubes, endosalpingitis, biosulfings, hydrosulfings, oophorytis, peritonitis, and pelvic abscess. Most common pelvic inflammatory disease in reproductive age: chlamydia more than gonorrhea. Virgins, genital TB, hematogenous. Menopausal females, E. coli. Copper iode users, actinomyces. Symptoms. Most common symptom is lower abdominal pain, bilateral. Increased pain during coitus. Acute phase fever. AUB, abnormal uterine bleeding. Menorrhagia, intermenstrual bleed. Postcoital bleed. Dysmenorrhea, infertility, vaginal discharge. Complications: Fitzhugh-Curtis syndrome, perihepatitis, violent string adhesions between liver capsules and anterior abdominal wall. Complaint of right upper quadrant pain. Most common chlamydia more than gonorrhea. CDC criteria for diagnosis: minimal criteria, additional criteria. Minimal criteria: lower abdominal pain with any one of the following per vaginal findings: cervical movement tenderness, adnexal tenderness, uterine tenderness. Additional criteria: temperature more than 101, abnormal cervical vaginal discharge, saline microscopy of vaginal discharge, abundant WBCs. Lab diagnosis of chlamydia, gonorrhea, increase ESR, increase CRP. Investigation for definitive diagnosis: ultrasound, tubo-ovarian mass, swollen tubes. Signs: waist sign, bead on string sign, cogwheel sign. Endometrial biopsy, endometritis. Laparoscopy is gold standard. Visualize tubes, adnexa and uterus directly. Specimen collection. Scoring for conception. Rule out ectopic pregnancy and appendicitis. Valence strings adhesions. Waist sign, hydrosalpinx. Beads on string ring. Dilated fallopian tube. Cogwheel sign, thickened endosalpingeal walls. Purest sign of PID: pus trickling from femoral end during laparoscopy. Scoring system for contraception in PID: Bohr-Meisel score, type of organism not included. Staging of PID: Gainesville staging. Colpotomy, drainage of pelvic abscess. Beat on string, ultrasound, PID. Hysterosalpingography, genital TB. PID, syndromic approach. Long-term consequences: infertility most common, ectopic pregnancy, chronic pelvic pain, hydrosalpinx, recurrent PID, Fitzhugh-Curtis syndrome. Management: OPT basis, broad spectrum antibiotic, injection ceftriaxone 250 mg IM single dose, tablet doxycycline 100 mg BD for 2 weeks, tablet metronidazole 400 mg BD for 2 weeks. Indications for admissions: not responding to oral treatment, pelvic abscess, pregnant female with clinically severe disease, pregnant female unable to take oral medications. Note: IV antibiotics continued for 24 hours after patient becomes afebrile. Plus oral antibiotics for 2 weeks. Advice: abstinence for 1 or 2 weeks, partner treatment, barrier contraceptive, avoid alcohol with metronidazole. Advice: abstinence for 1 or 2 weeks, use condoms. Indication: lower known case of lower abdominal pain, any one of the following: uterine tenderness, cervical motion tenderness, adnexal tenderness. Ensure that urine pregnancy test is negative, otherwise you'll have to rule out ectopic pregnancy. Treatment: patient number 6 yellow kit, tablet cefixime 400 mg stat, Tablet metronidazole 400 mg 2 times a day for 2 weeks. Tablet doxycycline 100 mg 2 times a day for 2 weeks. Partner number 1 gray kid. So we are not giving him metronidazole, but we are giving him azithromycin. So cefixime single dose and azithromycin single dose 1 gram. That's all for STDs and PIDs. Stay tuned for the next videos. Thank you.